Ansel Meyers is external faculty here at SFI. She also holds the Denton A. Cooley Centennial Professorship of Zoology at UT. Her academic accomplishments are manifold, but I think her recent work on COVID is most germane for our conversation today. Lauren is the founding director of the COVID-19 Modeling Consortia. She has advised the government at all levels about the spread of COVID and has done crucial work on the impact of social distancing on the pandemic spread. With that as an introduction, let me turn it over to you, Lauren.
Thank you so much, Will. I kind of don't want you to turn off the videos. I like seeing all these familiar faces. Hello to all my old friends. It's great to be here. All right, let me share my screen and get started. Okay, so let me, so Will just mentioned that I am the founding director of UT COVID-19 Modeling Consortium. And I'm gonna tell you start by telling you a little bit about what that is, and then spend most of the time talking about some of our recent activities in COVID. But so from day one, when we first heard about COVID on CNN or however we heard, my lab got right to work like all the other labs in my field, just trying to get our hands on whatever data were available, answer basic questions, and very quickly that escalated into requests from the federal government, the state government, who in Texas, who we've worked with for years and years, local authorities asking us questions. What should they do? What's going on? And it really very quickly got much too much for us to handle. And so with the support of my university and with a generous gift from Tito's Handmade Vodka, a special form of like liquid courage, and everything that I learned from being affiliated with SFI for over 20 years, I had the resources, I had sort of the confidence and the model to set up what's now the UT COVID-19 Modeling Consortium. And as described here, it's an interdisciplinary network of researchers and health professionals building models to detect, project, and combat COVID-19. Really what it was is I just put out a call to all my colleagues at UT, those I knew, those I didn't, people in my network of collaborators, and said, hey, let's start talking. Let's meet every morning at Zoom. There's a lot of requests. Let's see how many of these we can field. And it's very self-organized. We've tried to tackle as many things as we can if we have the right kinds of tools. And if you go to our website, this is a screenshot, you can see several dashboards, a bunch of publications. And I'm sure this is not a complete list, but these are many of the people that are responsible for the work that I'm going to be talking about today, that I'm working with on a daily basis. I've highlighted in green Michael Lockman, who's on the faculty at SFI, who's really been a key leader in this effort and contributed to a lot of the work I'm going to talk about today. So with that, we've done a lot of different things, and as have modelers all around the world. And I think that most of what we've done as a community can be categorized according to three different goals. We model to help us understand the threat. We model to help us forecast the threat, and we model to come up with good strategies and to support decision makers in containing the threat. And I'm going to organize the examples I provide today in according to these categories. We also, in the Modeling Consortium, have really kind of explicitly been modeling for three different audiences. The first audience is the policymakers, and this is one of my favorite emails I got in this whole thing, actually maybe my least favorite, but it was an urgent modeling request from the White House Coronavirus Task Force a couple of days after Ambassador Birx had been appointed. This is a time-sensitive and urgent request. Please see below the series of parameters and outcomes we would like you to model. We will need whatever results you can achieve by the close of business Wednesday. I think we got this Wednesday morning or something. East Coast time, or opening of business Thursday. Your results in that time frame will inform U.S. policies. And we spun our models quickly. We provided results. There's no evidence that they impacted policy whatsoever. So we also model for the public, and this is something sort of new to us, but we really are proactively, when we feel like we have insights, when we feel like we have dashboards that can provide useful public awareness, inform behavior that's aligned with the interest of public health, we've tried to get out there and talk about it. And then, of course, for scientific audiences. And while this is a published paper, many of us are trying to get our work out by medRxiv as quickly as possible. And I think that the fact this very rapid sharing has really accelerated the pace of science, because we're learning from each other, we're building on each other, we're not reinventing the wheel every time we try to model something different. If somebody comes with a request, for example, how to deploy testing to open a workplace or something like that, instead of building that model, I've seen that model and I can refer them to somebody else. Okay, so now I'm going to go give you a little bit of a whirlwind tour of some of the studies, some of the tools that we've developed since the beginning of the pandemic, again, organized around these three goals. First, understanding the threat. So a couple of the studies that we published, we did really within that first month and a half of becoming aware of COVID in early January. So very early on, we didn't know what was going on in Wuhan. The first reports were that there was this anomalous virus and it was spreading from animals to humans, but it wasn't human to human transmissible. And maybe a few days later, oh, there's some evidence that it's actually spreading in households, but limited. And then, before maybe a week or so was out, we knew that this thing had the capacity to spread from person to person in the community. We didn't know how many people were infected in Wuhan. We didn't know how fast it was spreading. We didn't know where else it might already be emerging in China or around the globe, but we wanted to answer those questions as quickly as possible. And we didn't really trust the data coming out of China. Maybe we didn't know if they were being completely transparent, but even if they were, we weren't testing for this virus yet. There was just really no way to know what the true prevalence was. So what data could we trust at the time? Well, we felt like we had some faith in the first 19 cases that were reported out of China. So the locations, Seattle, Taipei, Tokyo, the very first case was in Bangkok, and the date of those. And we also know, like many modelers in my field, we already had at our disposal international daily airline mobility between all pairs of cities around the world. And we also very quickly got our hands on cell phone mobility from within China for hundreds of millions of people. That reflected daily air, rail, and ground travel patterns between 370 different cities in China. So we used really those first 19 cases to triangulate how fast the virus was spreading in Wuhan. So we imagined very simple model. The virus is growing at some exponential rate. We know how often people are coming in and out. It's sort of like sampling from the city. And based on when known cases first arrived around the globe, we could say something about how fast the virus is probably spreading within Wuhan. And what we estimated at that time, very early on, in fact, our first estimates we did before the Wuhan lockdown on January 23rd, was that the virus had spread, far faster and far further than the data were telling us. By that January 23rd lockdown, when China was reporting a total of 425 cases, we estimated that there were probably somewhere over 10,000 cases already in the city. And that by the time of that January 23rd lockdown, it had probably already spread to well over 100 other cities in China where it was very likely there were already small outbreaks brewing. And in fact, within a few days or within a few weeks, there were data from all over China that sort of corroborated this, and many subsequent studies that have also shown that there were probably thousands and thousands of cases during that early period in Wuhan. The second study I'm going to mention was by far the simplest mathematically, but the most jaw-dropping from the perspective of just understanding, characterizing this threat. This was a study that, again, I think we started collecting the data from this, I want to say, late January, no, it was probably early February. We worked with a team of Chinese students who went to the websites of 18 different public health agencies from different provinces in China and looked for case reports that provided a few pieces of information. A person was infected. It also reported the day they first felt symptoms. It also reported who most likely infected them. And most case reports aren't able to specify this, but there'd be a few cases where a person was infected, there was no one else yet infected in the city, and their spouse had recently come back from Wuhan or something like that. And so they could connect the dots. So it had to also have sort of a likely infector and the date that infector first started exhibiting symptoms. And so we simply used those, what ended up being 450 case reports, to estimate the time between the infector developing symptoms and the infectee developing symptoms. That's a quantity known as the serial interval, and it tells us something about the pace of transmission. And I'll tell you that up to the point where we almost simply just made a histogram of those 450 serial intervals. And before I show you this, I'm just going to tell you that at this point in time, very early on, much of the public health community and the researchers, we really had no idea, but we were building models where this virus looks something like flu, but we were also building models where this virus looks something like SARS from 2003. And the thing about SARS in 2003 was it was a slow and visible spreader. It had a serial interval of about 8 days. So there's a good week between somebody feeling sick and the person they infect feeling sick. And people weren't contagious until they had symptoms. Okay. And this one study made us realize that in a very upsetting way, this virus was not like that first SARS virus. So this was the histogram, 3 really interesting things. So serial interval along the x-axis. Number one, this virus was spreading at about twice the speed of SARS, the serial interval closer to 4 days than 8 days. There was already, this is our first evidence that there was asymptomatic transmission, people actually spreading before they felt symptoms. And then on the long end, there was evidence that we would have to isolate people for quite a while to ensure against sort of longer term chains of transmission. And when we shared this histogram in its roughest form with our colleagues at the CDC, they looked at this and said, you must have made a mistake. Go back and check your work. And, in fact, we did make mistakes, but not that mistake. And pretty soon after, within a few days, there was another study using different data from China that corroborated that this thing was spreading quickly and that there was evidence of pre-symptomatic transmission. The third and final study I'm going to mention under this category of sort of characterizing the threat is something closer to home in Austin. So fast forward now to April. So I'm sorry, to March. On March 24th, Austin leadership, so the mayor, the judge of the largest county in the Austin area, they enacted our stay home, work safe order. That started on March 24th and went through the reopening of America on May 1st. And at the time when they enacted this order, they basically said everybody's got to stay home except for the essential workforce. And they put some pretty clear restrictions on construction work. Only the most essential projects could go forward. And within a couple of days, the governor of Texas overruled that and said, you guys can do your stay-at-home orders, but all construction work has to be allowed to proceed. And so the city was concerned about that. And they asked us if we could adapt our models that we were already using to project COVID in Austin to estimate what the impact might be in terms of increased risk to the construction workforce and the possibility that transmission at work sites could spill over and make things worse for all of us. And so we made these kinds of projections early on. So this is rate of hospitalizations on the y-axis, 2 different scenarios on the x-axis. Baseline risk means just according to our models, what we think would be the risk of transmission on construction sites. 50% risk means mitigation efforts are being put in place at work sites to reduce the chance of transmission. And these are just pairs of bars comparing projections for what proportion of construction work, or what's the hospitalization rate going to be among construction workers compared to other people in the same age group, but who aren't in that same workforce. And so you can see at the baseline, we projected that construction workers would probably experience 4 to 8-fold times higher COVID hospitalization rates compared to their counterparts. And when we sort of kept an eye on things because of this, the city of Austin started asking for occupational data from COVID-19 patients in hospitals. And so we were tracking that. And by the time we got out to, I guess this was early May, we actually looked at, and what you're seeing here is a model, a fitted model projection of that line. And then all the bars are actual hospitalization data from Austin area hospitals. The total heights of the bars is total number of hospitalizations for COVID in Austin. The dark green at the bottom are people who identified as construction workers. The medium green are people who gave their occupations but weren't construction workers. And then the light color is anyone who is didn't give their occupation information or wasn't in the age group we were comparing. And what we found when we looked at the data was that the actual excess burden in the construction workforce was predicted almost perfectly by our model. It was the relative risk of COVID-19 hospitalization among construction workers compared to same age group, different occupations was almost exactly 5. So they were much higher risk. So where is this coming from? Well, this is really, this illuminates disparities we've been hearing about from all over the country, different studies, different ways of slicing this. But this is one example of sort of the disproportionate burden that is felt by our racial and ethnic minorities that have groups that have overlapping vulnerabilities. In Austin, 66% of our construction force is Latinx. It's about 30% Latinx across the United States. Among Latinx construction workers, 48% roughly lack health insurance. This means that population has had less access to preventative care. Because of that, they have higher rates of comorbidities that put them at risk for severe outcomes. And they also, because of a lack of health insurance, are more likely to delay or not at all seek treatment for COVID-19, which can lead to worse outcomes. In addition, the construction workforce has higher rates of smoking and may be exposed to hazardous materials that would also compromise lungs, make it more likely you'll suffer severe outcomes. And this is a community that has to work on a daily basis to put food on the table. And so even if they feel symptoms and are told to stay home, if they have symptoms, they still might go to work out of necessity and thus expose their coworkers. And the Latinx community in Austin and many parts of the country have larger than average household sizes, which also contributes to the kind of community spillover of what happens on the work site. So, this is an example of how we can use modeling to kind of incorporate these different sort of complexities and early on make projections to identify high-risk groups. But more importantly, I think this is just another additional piece of data that is telling us that we've got to do something. We have to stop throwing our essential workforce under the bus and really take steps to protect them. That includes making sure that there are basic mitigation standards in workplaces. That means incentivizing workers to stay home if they or anyone in their household is symptomatic, and providing alternative accommodations to people who are really at high risk, have comorbidities, if they do get infected or exposed. So now I'm going to turn to the second category of modeling, which is modeling to forecast the threat. And the very first that I remember first request we got to forecast something was from the White House Coronavirus Task Force. And the question was, how many people are going to die from COVID by the end of the year? I think this request came in March sometime or February. And our answer was, there is no way we can forecast that because it absolutely depends on the policies you put in place and the decisions that individuals make. But we'll give you 3 plausible scenarios. A scenario where we do nothing to mitigate this, so there's no control. We would anticipate that there could, well be 1 million or more deaths in the United States by the end of 2020. If we all stay sheltered in place indefinitely, we could potentially cap the potential deaths under 50,000. And if we do something in between, which is essentially the roller coaster that we've been on, we anticipate somewhere between 200,000 and 400,000 deaths by the end of the year. So this is pretty simple modeling, but forecasting, but we really, since then have really gotten involved in much more sophisticated, more detailed, more kind of action-oriented forecasting. Our first, sort of real endeavor into forecasting was inspired by the IHME model, which many of you may be familiar with. It is, I think, the best known model, by the public and policymakers out of Washington. This was a group that wasn't, they weren't part of kind of the core community of modelers that I've been working with over the last decades. And they came in with kind of an alternative approach to modeling, which is known as curve fitting. Or into forecasting. And the idea was that they assumed that deaths, and this is just their original model, they've changed it since then, but the original model is they assumed that deaths would follow sort of a Gaussian shaped curve, a bell curve, and that the steepness and when it peaks and all those things would be governed by when governors enacted shelter in place orders that would lead the curve to start slowing, and that the overall shape of the curve would resemble the curves that we had just observed in China and in Europe. This model got a lot of flack, a lot of pushback, even though it was widely adopted by the press and by policymakers. A lot of the scientists didn't like it, partly because it was a little bit, I think, foreign and didn't seem at face value like it should work. It doesn't actually have, the opposite of sort of curve fitting is a much more mechanistic model that has some of the complex dynamics of virus transmission built into the model. And so I think there was sort of an assumption that this probably wouldn't work because it was way too simplistic. And then it was also criticized because it actually didn't hold up when we sort of looked at the backcast. So there are others who made graphs like this, but this is a graph we made where we compared the projections of their model for Spain in that shaded purple area. That's their 95% confidence interval with what actually happened in Spain. And you can see that their projections didn't quite capture reality. So we decided to sort of dig in a little more instead of just like throwing the baby out with the bathwater. We were intrigued by the curve fitting method. We thought there were some issues with how they approached it. And so the first forecasting model that we ever built was really just a variation on their model. The 2 things we did that were really different from theirs, one is instead of making assumptions that the shape of the curve should look like China and Europe. And instead of assuming that people's behavior automatically followed what governors ordered, this was probably one of the very first models that actually incorporated cell phone mobility data as a way to sort of directly estimate activity on the ground that might reflect pace of transmission. And so we adapted the model so that it could assimilate that kind of data. And in addition, we corrected what we thought was sort of a statistical error in how they were quantifying uncertainty. And I think our first model was a substantial improvement on IHME, but what we realized, and what I'm sure IHME realized as well, is that once we sort of exited that first nice shape wave and we started going in all sorts of directions, the curve no longer fit. And then we replaced that model with much more mechanistic type models. Those more mechanistic type models, which have sort of compartmental SEIR frameworks under the hood, we've used those, we've adapted those not only to make national level forecasts of mortality, but we've used them sort of more on the ground to really, I meant to mention that our models, our mortality models, in addition to models of dozens of other research groups now around the world, all feed into the CDC's ensemble. So they're looking at a lot of different forecasts to try to get sort of the most robust assessment they can of about regarding what's to come. So now I'm going to mention, so we've also been building models on a more local scale. And this is actually something that really Michael Lockman has really spearheaded for our consortium, but building models that tell us what's going on in Austin. And this is a screenshot from our Austin dashboard. On a daily basis, we provide estimates for the reproduction number. I'll say a little bit more about that in a minute, but it tells us something about how fast the virus is spreading. The probability that the epidemic is in a growth phase, the estimated 14-day change. So for example, in this screenshot, we're estimating that there are 44% more infections today in Austin than there were 2 weeks ago. And this model that's making forecasts, and we have a bunch of forecasts of what's going to happen in hospitals and in ICUs in Austin, and that's the real purpose of this dashboard. But this model is driven by really three things: the daily number of COVID-19 hospital admissions in Austin, the daily number of COVID-19 hospital discharges in Austin, and that cell phone mobility data that I showed you earlier that comes from SafeGraph and gives us a sense of what fraction of the day people are staying at home and how often they're going to venues like restaurants and schools and grocery stores. So this is an example of a somewhat recent forecast, maybe today, I can't remember, but this is showing just the hospital admissions. The dots are the observations in Austin, and the green line is our sort of backcast, and the future-looking lines, the purple line is a median trajectory, and the spaghetti lines kind of following the model of our colleagues in weather forecasting indicate equally likely possible futures. We also on our web page, and now I'm going to talk a little more about the reproduction number, provide the historical time series of our estimated reproduction number. So for those of you who aren't familiar, the reproduction number tells us something about how fast the virus is spreading. A value of 1 means that it's basically flatlining. And one way to think about it is like every person who gets infected on average is infecting one other person. And so every infection sort of replaces itself. Values above 1 indicate that the epidemic is going to be spreading exponentially. And values below 1 indicate that the epidemic should be dying out. And so what we see in Austin, so this is Austin going back to early March. In Austin, prior to closing schools and enacting our stay-home order, before we started mitigating this threat, it probably had a reproduction number somewhere between 2 and 4. So the average number of secondary infections was quite a few. We enacted these orders. They had the desired effect. The reproduction number came down somewhere close to 1, possibly a little bit below. And then we started reopening, and Texas was one of the first to enthusiastically embrace the Reopening of America plan. Early May, mid-May, and we saw the consequences of that by June in many cities across Texas, including Austin. And we saw our hospitalizations, our ICUs going up at an alarming pace. That led the governor to allow local authorities to impose some restrictions, including some face masking, but not comprehensive face masking. We took advantage of that as soon as we could. Then the governor closed the bars. Then there were statewide face mask mandates, and you can see those had the desired effects as well. And now fast forwarding, UT opened somewhere before the beginning of September. Students came back to Austin around August 18th. We've kind of been holding our breath to see what's going to happen. There were some clusters of cases, and UT is, usually 50,000 students. We probably have at least 30,000 back in town, hanging out at frats, et cetera. There's certainly been clusters of cases at UT. And I think just now we're beginning to see the effects of slow but certain spillover from that and other activities around the city. And we're seeing our hospitalizations start to creep up again in an alarming way. We're also we also have a dashboard showing these kinds of projections for all of Texas. And this is just looking at all, I think, 21, 22 regions of Texas, specifically ICU. And you can see what you're hearing in the news. If you look for El Paso, the horizontal dashed lines are ICU capacities. El Paso doesn't have enough, can't take care of the patients. They're coming to Austin and they're taking our healthcare workers. Abilene, Amarillo, you can see that much of Texas, though not all of Texas, is either past the brink or already on the brink of really catastrophic situation in terms of the integrity of the healthcare system and consequent loss of life. Okay, finally, on topic 3, modeling to really support decision-making, modeling to really think about, given all this uncertainty, what kind of decisions can we still make that make sense, that are robust? And this is a screenshot from one of Austin's 2 dashboards. They call this the key indicators for staging dashboard. The different colors correspond to different levels of restrictions, where red is stay at home, orange is like mostly closed restaurants, no bars, I don't know what we're gonna do about schools, et cetera, yellow and so forth. Probably have one of these in your own city. And so what you see here is the city tracking the 7-day rolling average of COVID-19 hospital admissions, and with a clear indication to the public that when we cross these certain thresholds, we're going to change our policies. We worked very closely with the city to not only kind of formulate this approach, but to actually derive the values that separate red from orange, from yellow from blue, et cetera. Okay, so how did we come around to this? Well, first, way back when we were thinking about this policy in April, the question was, okay, what happens if we open up America on May 1st? We tell people to be careful. They're a little bit careful, but they're not very careful, and we just see what happens. Then we projected we'd have something catastrophic in Austin. We would probably have surges that overwhelmed our hospital capacity. By the end of the summer, lots of people would die. Nobody wanted that. So the question was, what should we do? Given that, we want to avoid loss of life, we want to avoid loss of livelihood, we have to obey the laws of Texas, which are pretty strict. We're strictly strict on the side of not allowing local authorities to close things down. So what kind of policy could we put in place that is sort of allowable and aligned with what we hope to do? So the first step, and arguably one of the most important steps in building a policy, is to figure out, to explicitly state what your goals are. And what we arrived at that kind of satisfied those needs was that we want a policy that will ensure that we keep hospitalizations and ICUs under our local capacity. And if at all possible, let's avoid stay-home orders. Let's spend as much of our time open as we possibly can. What kind of policy options do we have to achieve those goals? Well, it's basically all the different rules under the different colors, different combinations of face masks, social distancing, gathering, restaurants, bars, et cetera. So those are kind of the levers we have to achieve those goals. And I'm not going to go into the details, but happy to talk about it more if you'd like to. But I'll just say that the solutions we came up with, very briefly, by building a detailed compartmental model of COVID transmission that was fit to data from Austin, and then implementing different kinds of thresholds for those different levels, and using numerical stochastic optimization to figure out which thresholds were going to allow us to best achieve those goals. Ensure that we keep those hospitalizations under capacity while absolutely minimizing the time we have to be under red and orange. So the solutions we came up with for the city were that we needed to track daily COVID-19 hospital admissions as the best data that were actually not yet at the time available, but that we could make available to give a real-time sense of how it was spreading, and then tap on the brake at the key thresholds that we derived. So again, I'm not going to go into the details, and we don't know how it's going to play out, and how it's going to play out depends on whether people comply with the policies, whether the city actually enacts the policies. But this is sort of a plausible future based on our model of the policy and fit to data up till recently. So the top graph is showing you our projections and history of that key indicator variable, that 7-day hospital admissions. And what you see, and this projection started on October 7th. Red dots are actual data. Light blue lines are equally probable future trajectories. They're individual simulation traces. The darker blue line is just one representative sort of central trend. And then the horizontal colors show the policy. And so when the simulation hits a threshold between two different policies, it changes the transmission rate according to transmission rates that we estimated different points in time in Austin. And what you see on the bottom is the resulting outcome. The thing we're most worried about is the integrity of our ICUs, our ability to have beds and care for ICU patients. So that horizontal line is what we hope never to exceed. And so you can see that this is the corresponding ICU trends for each of those simulations. The sort of Dali-esque background colors, each one of those, if you look on a given day, that's telling you what proportion of simulations were in red stage, orange stage, yellow stage, blue stage. And so what we expect under our current projections, if people behave and the policymakers behave as prescribed, that we're going to have to be under pretty severe lockdowns to prevent overwhelming ICUs over the next few months. And we may even have to go into some short-lived, full-blown lockdowns in order to ensure our healthcare, the integrity of our healthcare system. What about other alert schemes? So we derive this one from Austin, but there are so many different alert schemes. So many cities, so many countries have developed them, and they may all be based on really, rigorous sort of analysis or good analysis of whatever kind. But it's hard to know when you go to these websites, you look at these dashboards, they rarely provide any information or sort of rationale for why they're tracking the data they're tracking, why they chose the thresholds they're choosing. So, hopefully they're decent. However, when you look at the state of the world today and how many communities are actually facing overwhelming numbers of hospitalizations and are really desperate, something's not working, at least in some places. We, in an attempt to kind of just start to think about, these sort of more intuition-based systems, are they going to work? We have done a little bit of a comparison between different alert stages. So what you see on the x-axis is, and this is all projected for Austin, like what if we implemented other people's alert systems in Austin? Along the x-axis is the projected peak ICU. That horizontal line is what Austin's ICU capacity. So if you're in that gray area to the right, that means you have overshot capacity and you're in a bad state. And then the y-axis is days in lockdown. So you want to stay kind of to the left of the ICU capacity and as far down on the y-axis as possible. You want as few days as possible in lockdown. And each one of these different dots is a different simulation, and each color corresponds to a different policy we simulated. So that black sort of line that's sort of there in the middle, those are simulations of our own policy. You see they kind of come right up against ICU demand. They're supposed to guarantee with 95% certainty that we don't overshoot, and you can see a few of our dots do overshoot, but we managed to keep the needed days in lockdown under a couple, or just to about a couple weeks. The other two I'm going to mention are France's policy, and that sort of greenish yellow color. So that is one that's been in the news a lot, where France, they have multiple stages, but the one we've heard about a lot in the news is that when their ICUs, when 30% of their ICUs are occupied by COVID cases, that is when they lock down their cities. And when we implement their whole stage process, what we find is that trigger is too late. That it's very possible that if they wait until 30% full ICU to really lock things down, even if they have those intermediate steps beforehand, they will overshoot their ICU capacity. And at the same time, require even more time in lockdown than the Austin strategy. And that is partly because they waited too long. The longer you wait, the longer you have to deal with a really, high level of healthcare demand, and you end up having to stay locked down longer on the back end. And then Harvard's, the Harvard Global Health Institute, they published a very kind of widely cited, used set of recommendations for when it's safe to reopen schools and reopen communities. And it's based on incidence, so number of cases per 100,000 in the community. Their criteria for locking down is when the 7-day average of incident cases exceeds 25 per 100,000. And then they have other thresholds for like partial lockdown, et cetera. And what we estimate when we plug that into our model is that that's erring on the side of caution. It is very likely if you implement those that you will preserve the integrity of your healthcare system. However, you may end up spending, more time in lockdown than needed. So in closing, so I realized this morning that I was given a title, which was lessons learned and next steps. And so these are some lessons learned that I thought of as I was thinking about this talk this morning. I'm sure there are many other lessons learned, but let me just share a couple. So one is that, what we have seen throughout this pandemic is an utter failure of preparation. And if you've seen me give talks before on my work in pandemics, you may have seen these pictures before. These are things I pull out a lot. They are on the left, the video is a video of a pandemic simulation app that we built for the state of Texas by 2012, 2013, after 2009 pandemic H1N1, so that they could run pandemic preparedness exercises and simulate all different kinds of pandemic threats, see what happens if they do different things with vaccines, antivirals, social distancing measures, even see it through the lens of a noisy surveillance system. And what you see on the right is our good friend Sam Scarpino presenting the same model deployed on this big visualization wall of monitors for representatives from CDC, from NIH, from our peer institutions that came and took a look at it back in the early teens. And I mention this because the state of Texas probably paid $500,000 for this and some other tools that we built for them. And they promptly shelved them and totally forgot they were there, never did a single exercise. And that was because the person whose vision it was in the state agency went and got a higher paying job in industry. And so, this arguably got the closest a state agency ever got to having like models in-house to support decision-making and planning and thinking through different intervention strategies. And it never really played out. So this is one of many examples. And this is what happens when we have sort of an impoverished public health system and really no good bridges between research and practice at the front line and, in public health. Moreover, I think this is an utter failure of imagination. Even though we and others have done all this great work in the past, we all thought the next pandemic was going to be flu. None of us really thought about like shutting down businesses and schools for such a long time. We really have a hard time thinking about anything beyond what we've, slight variations on what we've experienced in the past. And so really, I think these are the two most important lessons learned, kind of at a very high level. We also have learned, as we have been really working hard, and others around, other really brilliant people around the world have been working hard to try to forecast this pandemic, is that we have a painfully short forecasting horizon, even though we know a whole lot about this virus really now about, like sort of its pace of transmission, asymptomatic, symptomatic. There's still things we don't know about age-related susceptibility and infectivity, but there's a lot we understand. What we absolutely don't have a crystal ball for is human behavior, human decision-making, political choices, innovations. Like when are those vaccines coming out? How effective are they gonna be? For how long, right? So we don't have a crystal ball for that, or exogenous events. When the hurricanes came through Texas, we suddenly had tens of thousands of people going from Galveston to Austin, staying downtown, right? These things can impact the transmission dynamics of a pandemic, and we haven't figured out how to predict them, or even really how to, even if we can't fully predict them, really incorporate them in a coherent way into our forecasting models. Then getting kind of more down into the details of what I talked about today, some of these alert policies are better than others. Probably few are validated or really, given any kind of like quantitative push. Timing is absolutely critical for our interventions. One or a week delay in implementing lockdowns or stricter measures can really make the difference between having your hospitals overwhelmed or not. Hospital admissions are a good data source to track to get good information about what's happening in your community. It turns out, I didn't really talk about this, but ICU personnel are absolutely the limiting resource in most communities around the United States. And then there's all these other things, which I didn't think I'd talk about, but probably resonate with a lot of you. It seems like in the United States, politics often trump science. Masks turned out to be useful. Contact tracing turns out to be less useful, yet we are holding on to it so much in the United States. it's not useful in the sense that if we're not using some of these new digital technologies and we're letting this virus spread at such high levels, we just don't have the resources to really make a dent in transmission with contact tracing. Testing turns out to be a promising path to opening. We have seen catastrophic overlapping vulnerabilities really causing such extreme burdens in some of our racial and ethnic minority groups. And this thing that's I just can't get over, I mean, time and time again, is that in the United States, it feels like opening bars is so much more important than opening schools. Finally, really next steps, taking a step back, I think going back to like the key lessons learned. Next steps, things that we're working on in the consortium that a lot of people in our world are working on: safe opening of schools and colleges. How do we use surveillance testing to do that even more so? And working with the state and locals to figure out how we're going to roll out that vaccine as safe, as effectively, as fairly as possible. Finally, taking a step back, I really think next steps for understanding the threat of pandemics, preparing our globe for the threat of pandemics, this is where SFI really can step up. I mean, it already does in so many ways. So, you know, the not really in the failure of preparation, but the failure of imagination, you know, really understanding not just what kind of like viruses might come our way or pathogens might come our way, but what is that really complex cascade of things that happen because we have a pathogen in all different dimensions, in social and economic, in political, in cultural, and, you know, you name it, in technological. How do those feed back? So really imagining what threats look like, and then imagining the universe of solutions, figuring out, even though there's so much uncertainty, we don't know what's going to come our way, there must be things we can, that will be at least robust path forward, robust ways of collecting data, robust ways of making decisions, et cetera. And then I also think, on a related note, that SFI can really help on tackling this challenge of expanding our forecasting horizon by really thinking about these complex interdependencies and folding them into our models of pandemics. So with that, I want to again acknowledge all the people that were on my early slides, and happy to have a discussion.
Awesome. Thank you so much, Lauren. That was a great talk and extremely timely. As a few people have already noted, our governor ordered a 2-week shelter in place here in New Mexico earlier this afternoon. So yeah, that was wonderful.
Oh, really?
I do want to open it up for Q&A. David, do you want to kick us off?
Yes, thanks, Lauren. That was great. Yeah, so very early on in the pandemic, people were talking about endemism, right? Would it become a permanent fixture? And John Mactor made this really nice point about tuning to the critical point, where the critical point here is R0 equals 1. And the problem as he saw it was that what happens, of course, is we implement a policy like mask use or social distancing. We reduce transmission. You have a dashboard. It says we're now in the we're now in some safe zone with respect to our thresholds, and now we go out again, and you open businesses again, and you become imprudent again, and it increases, and then of course we move into another zone and we go down. So this is SO, self-organizing criticality. How do you avoid that dilemma? It seems to me almost inevitable.
So, I mean, one way you avoid it is you get safe and effective vaccines and you vaccinate everybody, and then you achieve true herd immunity, right? There's, you know, this, you know, that if herd immunity is such a complicated concept, but this idea of herd immunity, you have to, some fraction of the population has to be immunized either through vaccines or through direct exposure to the virus. And once we get to a certain point, the virus will, the reproduction number will come below 1, and it will, the epidemic should fade out on its own. However, if everybody is wearing face masks, then that herd immunity threshold gets lower. If only, you know, 20% instead of 50% of people are infected or vaccinated, then under a world of face masks, we achieve sort of eradication. But if then we stop wearing face masks, and this is what you're talking about, David, right? So if we have a safe and effective vaccine and we vaccinate up to the true naive herd immunity threshold, that's one way out. And, you know, until then, we really are stuck in this world where we may have to live with precautions that basically the precautions themselves are bringing the reproduction number down below 1.
For our next question, let's go to John Giannakopoulos. John?
Hi, thanks, Lauren. That was terrific. I have a very simple, practical question. I'm at a university, like most people are, with a great hospital, which for a long time wasn't doing very much. And I was amazed that they themselves couldn't do any testing. And Yale farmed the testing out to somebody else in Cambridge, actually. So my question is, if Yale, say, could test every student every morning and get the result back in 15 minutes every day, could Yale operate as normal? Does your model answer questions like that? With that degree of testing, would it make any difference? Nobody seems to try to do more than twice a week. Would it make a difference to do it every day? And especially if you had one of these fast tests, let's say it had a high accuracy rate, would that allow businesses to open and act normally, or is that not really worth it? Apparently it's not, because nobody's doing it, but I'm surprised.
Yeah. So I mean, there've been some really nice work done on that, including by Michael Minna, who I know has spoken to SFI before, and Michael Lockman actually has also at SFI has actually developed a nice little app for looking at how, as you change your frequency of testing, how does that change the speed with which you would catch clusters, or whether you prevent clusters altogether. And so, yeah, there are definitely models out there that address that. And this sort of like twice per week or every 3 days has become this rule of thumb where you can almost go back to normal if you can achieve that level of testing. Everybody, every 3 days, you're sort of almost guaranteed that nothing's going to slip through, especially if people wear face masks, right? Then you kind of got that extra guard. I don't actually know off the top of my head whether if you go to every single day testing, given the, and with these rapid tests, they're antigen tests and they're less accurate than the PCR tests. If you factor in the lower accuracy of the antigen test and you go to everyday testing, what kind of assurance it gives you. But certainly it gets you even closer to going back to life as normal. And if everybody's willing to wear face masks, then it may be overkill,
So that suggests that things really aren't that bad. I mean, many businesses could maybe afford to do it. It's not that expensive.
Yeah, I mean, I do think that testing does provide us a way to open things up even more, but I think we also have to think about, once again, I mean, it might make it easy for Yale to open and some of the companies that we work at in the room, but no guarantee that the construction workers are going to have access to it, right? And as long as there are people going to work and doing things that where they're not being tested before they do things, there's still going to be community transmission, right? And so it's just, but it might be an answer for some of us to go back and do some of the things we want to do.
Thank you.
Take another question from Simon Levin.
Hi, Art. Wonderful as always. In your modeling projections, how do you deal with, if at all, with the differences between naturally acquired immunity and vaccine-acquired immunity, including the possibility of waning, and more generally, the heterogeneity that might exist within the population in terms of various attributes?
So with vaccination, we are actually still in the process of building in our vaccine models, and we're very much trying to tie them to whatever clinical data come out about, that tell us anything, which, we really have none yet, but there's some, like very early phase 1 and other experimental data that tell us something about, antibody levels. And so we're trying to build that, whatever data we can, into our models about specific vaccines, but we're waiting for a lot of that data to be able to do it.
Is it all antibody levels, or is it T cell levels too?
I think the data we've looked at so far is just antibody levels, but those are models in progress. We'll take whatever, insights there are into, indirect or direct information about what to assume. So there's, a lot of uncertainty there. And those are really in development still. With respect to heterogeneity, are you talking about heterogeneity in susceptibility, those kinds of things?
Yeah, correct.
Well, in the models that I'm talking about today, that I talked about today, these are mostly kind of garden variety, elaborated SCIR age structured models where we have, number of different age groups, maybe 5 or 10. In each age group, we have low risk, high risk, and we have some age specific assortativity that impact like transmission rates, based on what the age groups of the two people are. But in addition, we have also taken, and I don't know if everybody is familiar with, there are a couple preprints that have really gotten a lot of attention that claim that the herd immunity threshold is actually much lower than most of our models say it is, that it could be as low as like 7, 8, 9%, 10% of people. These are, and they've gotten a lot of traction, these studies. They are, although not totally explicit, they are the basis, for example, for the Great Barrington Declaration, which asserts that it's written by a lot of well-known scientists, that asserts that we should open things up completely for young, healthy individuals. And it's basically kind of a herd immunity strategy. So we have also taken a closer look at those studies that claim these low herd immunity thresholds. In fact, we've re-implemented them and looked very closely at the assumptions. And what we find is that the results they get, where they get this very low estimates for herd immunity, for the herd immunity threshold, they're based on fitting their model to data in 4 different European studies up through sort of end of June or July, I forget. So before the new surge. And they make some assumptions about the magnitude of social distancing measures during that period of time, which are not crazy, but probably not the most realistic assumptions. And it turns out that the numbers they get are very highly sensitive to those assumptions. So if you change even slightly what you assume to have been the impact of social distancing measures during that time, you get very much higher estimates for the herd immunity threshold. So in short, I mean, we believe that there really probably is more heterogeneity in the world than we're capturing in our SEIR models, but not so much that we believe that the herd immunity threshold is substantially lower than we're kind of, most of us are assuming at this point.
Thank you.
John Chisholm.
Lauren, thank you so much. Thank you especially for your service. I had a narrow question and a broad question. The narrow question is, on the chart before Texas on the brink, it looks like there's some periodicity, maybe weekly, in the data. Is that an artifact of people's behavior, what they do differently on weekends, or perhaps on data collection when they tend to go into the hospital, or perhaps something else? And then on the question of herd immunity, and I really appreciate this discussion in the last few questions, is it, if you can get the virus again and you can be reinfected, is it possible herd immunity could never be reached or might never be reached? And you said there's a assumed sort of broadly accepted level of herd immunity that you accept in others. What is that level approximately? Thank you.
Okay, those are great questions, John. Okay, so first, to answer the question of why there's this weekly signal in those reproduction number estimates, it's because there's 2 sources of data that are feeding our estimates. One is the hospitalization data, and the other is the cell phone mobility data. And a lot of that is coming from the cell phone mobility data, just weekday, weekend patterns that are driving that kind of that. And you know, part of that might be an artifact of the data, but part of that might be real, because we really are trying to estimate daily transmission rates. And so if people are out and about less on weekends or more on weekends, depending on where they're going, it could actually lead to upticks, on the weekends when people are out doing things more recreational. So that's the first question. The second question about herd immunity, yes, absolutely. If immunity is super short-lived, then, there's we don't get any herd immunity. If herd immunity is like, let's say for a year, then, or if immunity lasts a year following infection or following vaccination, let's say, then we can build up herd immunity in a season. I mean, this is sort of what happens with flu, right? Like we can get flu multiple times during our lives, but we actually, the reason, one of the reasons that flu tends to fade away in the spring and it's gone for the summer is at least we have sort of transient herd immunity, where, enough of the population is immunized for a short amount of time before, there's enough susceptibility. And so it could be that, we may never, it does seem likely that this thing doesn't confer lifelong immunity, and that our vaccines won't. And so we may be in one of those situations where we're not going to eradicate this virus through herd immunity, but we might be able to kind of control seasonal cycles or keep it, low through, or sort of keep it completely under wraps by vaccinating enough people on a regular basis. And then what is the assumed? I think that it was, so the assumed is under the assumption that this is immunizing indefinitely or for a long enough period of time that, so this is assuming there's that immunity is fairly complete. Under that scenario, depending on the model, I think that, the estimates are somewhere between 40 and 80 or 50 and 80%, I would say, are what I hear from other modelers. It depends on the assumptions of the model, but there's a lot of uncertainty.
Thank you.
I think we have time for one last question. Let's go to Andy Dobson.
Hi there, that was a fabulous talk. Really, really enjoyed it. Good to see you. Gillian Tett, in another fabulous talk this morning, told us we have to stop having tunnel vision and looking in different directions. So sort of two thoughts on that. One, everyone's hoping we get to herd immunity, but we won't start putting selection on the virus to change. We've seen lots of neutral selection, but we haven't seen any change. It's going to evolve once we have herd immunity, and it's probably either going to be better at transmitting or its virulence is going to change. How much does that worry you? And is that the sort of iceberg that's hidden under herd immunity? And then the second question is, as epidemiologists, we've got fantastic models of age-dependent variation in transmission and how age structure affects transmission, but we haven't got any models of how transmission between different sectors of the economy affects transmission, because the population is subdivided into people who are engineers, people who are doctors, people who are working in bars. Would that be a way to go? Because you could then couple the epidemiological models to economic models and look at what you're doing to both controlling the disease and impacting the economy in the same sort of framework.
Wow, those are great questions. I don't think I have answers to either one, but I want to go follow up on both. So as far as selection pressure that will change phenotypic characteristics of the virus, I don't know. I mean, I haven't looked at it. There are probably others who are trying to anticipate some of that. We don't, with flu, which I've spent a lot more time thinking about, we do see variation from one season to the next in terms of severity. Not a lot of it, well, and the transmission rate, but some of that may come out of not intrinsic differences in a very quickly evolving virus, but it could also just come out from the changing landscape of immunity from one year to the next, right? Based on who's been infected in the past. So I'm kind of avoiding the answer. I don't really know. I think it's a really important question. And I think we don't have a lot of great precedents for what to expect. And I have heard from my friends who know more about coronaviruses than I do that they expect that it would be slightly less phenotypically pliable than influenza viruses, but I don't really know where that comes from. And then with respect to the thinking about structuring our population along occupational categories or industry domains, or, I forget how you said it, that's really interesting. And I mean, I certainly, I haven't thought about that. What we see with, what we've seen in some communities is that there are clear kind of hot spots that are around industries or specific things, right? Like we have the long-term care facilities where like a clearly delineated place that something special was going on, impacted in a certain way by the community and vice versa. Our study on construction workers, we've seen these meat packing plants, be these amplifiers in certain communities. Schools, we're not seeing so much, but certainly could be for a different kind of virus. We know that for influenza. And healthcare, and there's something else I was going to say, but anyway, I think it's really interesting. I'm still thinking about it from an epidemiological perspective, but thinking about coupling that with sort of economic modeling could be quite interesting. And I know that Doan Farmer has done some really interesting work looking at kind of that interface between epidemic dynamics and industry economics. But yeah.
So I know we are running out of time, but let's try to squeeze in maybe one last question if we could. Jeffrey, did you have something that you wanted to ask?
Thank you. Yeah, it's great. First of all, thank you, Lauren. Excellent talk as usual. I enjoyed it. But I was, the part I liked best was the last kind of 5 minutes, because you talked about something that Andy touched on, and that's what I'd like to bring up. And that is, you stopped talking just as an epidemiologist, and you talk much more like an SFI person. And the big question is, how does this pandemic interface with the economy, with the social structures that we have, with the psychic well-being of citizens, with and so on and so forth. Everything is interconnected. That's why there is an SFI. And so I'm wondering, first of all, have you actually given much thought to that? You have these huge collaborations. Is it all, quote, just, I don't mean epidemiology, or are there people thinking beyond the boundaries? And if not, then I want to echo what I think you said, is that this is something that SFI ought to be doing, or given what you know, is there any place doing any of this in any serious way, trying to see the thing much more in a systemic, holistic way?
I would say, I mean, I've been thinking about this a lot, and I think, and my motivation in creating this consortium was to try to bring in other perspectives, and we certainly have. Like, we've talked to other people, and there are some people contributing to some of our models, but at the end of the day, our models are pretty much still in our lane of epidemiology, and I think that, and I don't know of places that are really doing this from a holistic perspective. And that's why my last slide had Santa Fe Institute across the bottom. I think Santa Fe Institute is perfectly poised to do this. And I wish I could be in person at SFI right now, talking to all of you and really thinking about how do we build those bridges and how do we kind of build those kinds of models. But I don't think we're there yet, but I think it's desperately needed.
So unfortunately, we really are out of time. I want to thank Lauren again for an outstanding talk and discussion. Again, applause doesn't really work well over Zoom, but you can do it using the reaction buttons on the bottom of your screen. There we go. Thunderous applause.